bringing us to a close for the lectures is going to be Dr. Leen Alblaihed. Dr. Alblaihed graduated from our emergency medicine residency training program a handful of years. Chief resident while doing an emergency ultrasound fellowship. After that, she did a faculty development fellowship and ACEPS teaching fellowship. And she's really focused her career and her academic niche on emergency echo and emergency cardiology. She's been lecturing nationally and internationally. And many of you probably heard her give some really fantastic lectures on emergency echo at last fall's Crashing Patient Conference. And in addition to emergency medicine, she also has a master's degree in healthcare administration from the Johns Hopkins Bloomberg School of Public Health. And Dr. Alblaihed is going to be giving a talk very relevant to this day and age on COVID-related dysrhythmias, which I'm sure all of us have been grappling with over the past year or so. So Leen, thanks for joining us, and go ahead and take it away.
Thank you. Can you guys hear me well?
Yep, sounds great.
Awesome. All right. Thanks, Amal, for that intro. So yeah, today I'm going to be talking to you about COVID-related dysrhythmias. I'm trying to see why my slides are not advancing. Oh, there you go. All right, cool. All right. So before I start, I don't have any disclosures to mention. About a year ago, a little bit over a year ago, Wuhan has become the most famous city in the world. Every news outlet, every social media, every newspaper started talking about Wuhan because that's where COVID-19 started. And we heard a lot of sick people coming in from China. It has been devastating their hospitals. A lot of people were being put on vents and dying. And soon, the entire world was engulfed with COVID. Every country and every city, everyone was dealing with COVID. And it was pretty unknown at the beginning because we didn't know what exactly we were dealing with when it comes to COVID. We knew it affected respiratory system, but a lot of people were getting really devastating outcomes and dying from it. And so we can see Italy also was hit pretty hard at the beginning with death rates just spiraling out of control. I know they're doing really well because they're hosting the European Society of Cricket this week, and they're actually doing well. But I digress. The U.S. also has been hit really hard, and it's still, till this day, trying to overcome this pandemic. And the death rates just keep going higher and higher. We, as healthcare providers, have been started to use PPE. I know there was a lot of shortage at the beginning, not just in our country, but everywhere else. We have to don and doff before going into every room. We just didn't know how it was transmissible at the beginning. Was it airborne? Was it droplet? How do people get it? And I know a lot of people, so I still don't know why toilet paper was missing for a good 6 months at the beginning of the COVID. Still cannot make that connection between toilet paper and COVID, but alas, there was no toilet paper in supermarkets. People were just going crazy, buying everything off the shelf. They were scared. So people in the public were scared because of what they're hearing in the news. Everybody was coming up with their own masks or a way to protect themselves. We know it's a coronavirus. We know it had spike proteins. We know it's a respiratory illness, but a lot of the people ended up on vents. A lot of people ended up in the ICUs, and a lot of them have been dying. So it's not like any other coronavirus or any other virus we've been dealing with, at least from the death perspective. Like, there's a lot of people dying, maybe because it was spreading too much. So we were still learning about what's happening with COVID. It has taken a toll on us. We were going into work, seeing a lot of people die no matter what we do. It was very sad. There was a lot of burnout. I know for a fact a lot of people have been isolating from their families, trying not to bring it back to their homes. I personally also isolated at the beginning. I just didn't know if I was contagious or not, because we know there is a lot of asymptomatic carriers. And so you just were worried about bringing it back to our families and friends. And unfortunately, we have lost a lot of people along the way. So a lot of healthcare workers have passed away from COVID. And I know each of us have been either directly affected or know someone who has been directly affected with COVID. What we do know is initially it was a disease of the lungs. So we get x-rays or we get CAT scans and we say, COVID lungs, COVID lungs. they have ground glass opacities, the patient has COVID pneumonia. But then later, we started learning more and more about symptoms that showed up with COVID. So loss of smell and taste, coughing, fever. People started presenting with GI upset. They would come in with diarrhea and vomiting and then turn up to have COVID. A few months later, we learned about even more different presentations of COVID. Covetose, we learned about blood clots, strokes, encephalopathies, chest pain. People would come in with STEMI-like picture and end up having clean coronaries and they test positive for COVID, or they come in with florid myocarditis. And so this disease kind of presented in every way possible and it was super confusing for everyone. And I thought I knew pretty much what everyone else knew. I tried to keep up to date. I was reading all the journals, all the articles that came out, until December 5th of 2020, when I was working one of my shifts and I treated David. And David was one of our EMTs. And he comes in, he's like, hey, doc, my heart doesn't feel right. And it's kind of going a little fast and I have palpitations. So I get an EKG and this is what I see. I'm like, okay, why is this healthy young guy with no medical problems, no drinking, no drugs, come in with this tachycardia that is irregular, atrial fibrillation? A few minutes later, 3 or 4 minutes later, this was his EKG. And I'm looking at the monitor and he keeps changing his rhythm. And he goes from AFib to SVT to PVCs with fusion beats. He goes into sinus, back into SVT, and so on. And I was just staring at it, looking at him. He was very stable. Blood pressure was okay. Temperature, he's speaking to me. He just feels palpitation. Pulse ox was okay. The only thing was the EKGs that keep changing every few minutes. So I called one of our the cardiologist on call, and I was like, hey, I have this guy, pretty healthy, but these are his EKGs and I don't know what to do with them. And he said, well, does the patient have COVID? Because cardiology has been seeing more and more AFib with COVID. And sure enough, I asked David, and he told me that his only thing is that he had COVID 3 weeks ago. He's recovered COVID, but that was his only risk factor for having arrhythmias. So, I mean, I was thinking to myself, I know the cardiology complications of COVID. I know it causes myocarditis. I know it causes heart failure. I know it can present an ACS picture, but can it present with arrhythmias as the initial presentation? So I went back to the drawing board, drew up some articles. And this was one case series from China that looked at cardiac injury with patients with COVID. And they looked at 146 patients. They found a 20% incidence of cardiac injury in those COVID patients. And in those patients with cardiac injury, they had a very high mortality, 51.2%. Another case series from China as well looked at 187 patients. Again, a high incidence of 27.8 of cardiac injury and an even higher mortality of 59.6. All right. This study was super interesting. It's from Germany. And they looked at 100 patients who are COVID recovered. So these are people 2 months, so 60 days to 90 days after COVID with a mean of 71 days. And they got cardiac MRIs on them. 78% of them had cardiac involvement, 78 of people who recovered from COVID. 60 still had ongoing inflammation. And even what's worse and scary is that it had nothing to do with how severe their COVID was or the course of illness. These are people with mild, moderate COVID. In fact, only 30% of them were in the hospital or needed oxygen. The rest were at home recovering well. And so that was a pretty scary number and scary study for me to read. So now I know it's pretty common. About 1/3 of hospitalized patients have cardiac involvement. It's associated with greater need for ventilation and also has a higher in-hospital mortality. The new thing I learned is arrhythmias are actually a manifestation of COVID, and it's actually one of the major complications of COVID. Okay. So I was interested in other viral illnesses. So SARS before COVID, which is also a coronavirus, had a high incidence of tachycardia, regardless of the fever. So these are people who were whether they're afebrile or they took into consideration the fever, they were still tachycardic or bradycardic. Middle East respiratory syndrome also had a high rate of arrhythmias. And then influenza, we know, causes tachycardias, blocks, or even myocarditis. So it's not unheard of for viral illnesses to cause arrhythmias. So how common is arrhythmia in COVID? Well, We still don't have all the data, pretty limited. A lot of them are case reports or case series. One of the studies mentioned that it was the leading complication after ARDS, about 20%. So that's a high number of people who have COVID presenting with or having a complication of arrhythmias. A case series from China said that about 7% of their population, or sorry, COVID population, presents with palpitations initially. Another study was 16.7 presenting in arrhythmias. Now, those were ICU patients, but still, they had a high incidence of arrhythmias. Another case series showed that 5.6% had VTAC or VFib. So not just atrial arrhythmias or AFib, but actual ventricular arrhythmias. All right. What about in the U.S.A? Well, we have data from New York. It says 7% had atrial arrhythmias, and arrhythmias are more common in critically ill. And then another study also from New York said 16.5 had atrial arrhythmias. Those were all ICU patients. So the data is coming. We know that there's a lot of arrhythmias, especially atrial arrhythmias with COVID patients. And what kind of arrhythmias? Well, all of them. Literally every arrhythmia you've studied has been reported in COVID. Now, the highest one was atrial fibrillation. 21% of incidents of arrhythmias in COVID were atrial fibrillation and atrial tachycardias. But there were reports of A flutter, SVTs, AV blocks, bradycardias, VFib, sustained or non-sustained VTAC, polymorphic VT torsades, QT prolongation, pretty much everything. But atrial fibrillation had the highest incidence among those COVID patients. Now the question is, how? How does COVID affect the heart or cause arrhythmias? Well, there are two ways it can do this. It can either directly invade the heart and cause damage locally to the heart, which causes arrhythmias, or by affecting all the other systems in the body, whether it's the lung, the immune system, the kidneys, and from there, whatever effect it has on the systems, it will affect the heart and cause arrhythmias. So let's take a look. So we know COVID affects a lot of the organ systems, and we'll take them one by one. So let's look at cardiac, right? So we're talking about direct cardiac damage from COVID. So the SARS-CoV-2, which is the virus that causes COVID-19, binds to the ACE2 receptor. This is how it gains entry into the cell. And once it gains entry, it starts replicating. And after replication, it emerges from the cell. But when it does, it actually causes damage to the host cell. Not only that, it actually causes an immune response as well. So binds to the ACE2, goes into the cell, multiplicates, goes out of the cell, but damaging the host cell and also causing an immune response. Another way the SARS-CoV can actually cause damage is also by binding the ACE2 receptor, but what that does is it downregulates the ACE2 receptor. So now the angiotensin 2, which normally binds to the ACE2, has nowhere to bind. And so it starts going up or increasing in our system. Angiotensin 2 has really bad effects. So it can cause cardiac remodeling. It has a vasoconstrictive effect. It is actually very pro-inflammatory. So just by taking up the ACE2 receptor by SARS-CoV, angiotensin 2 accumulates, and that causes a lot of the inflammation and also fibrosis and cardiac remodeling. So we talked about direct myocardial invasion. There's cardiac myocyte damage from the virus itself, which causes scarring. It can cause heart failure and also affects the conduction system if those are just the cells that are affected, and also causes myocarditis. So I want to speak a little bit about myocarditis because it's pretty big in COVID. And we talked about how myocarditis occurs from direct invasion, but it also can occur from the cytokine storm or from macrophages traveling from the lungs, for example, from the cell-mediated immunity, CD8 and T cell. So they all cause damage to the cells of the heart, the myocytes, which causes inflammation, which causes myocarditis. Myocarditis is very pro-arrhythmic. Hearts are very prone to arrhythmias when they have inflammation because of electrical imbalance. It also alters the gap junction, which is where the electrical impulses travel between the cells. It can cause ion channel impairment. So the sodium, the potassium, the calcium channels that are needed for the action potential, those are impaired because of the inflammation that's going on around there. It causes abnormal repolarization, and I'm going to touch upon that in a second. And also later on, so even if myocarditis doesn't cause arrhythmia early in the inflammatory stage, after recovery with the scarring, it can actually cause reentrant tachycardias, which is a problem. So let's talk about abnormal repolarization for a second. Now you will recall this is the normal action potential. Basically, sodium goes in, calcium goes in, which is the plateau phase in blue, and then potassium goes out of the cell to go back to the threshold, right? So we kind of all remember that. What happens with COVID is there is abnormal calcium channel handling and also abnormal potassium handling. And so the action potential is actually prolonged. And this makes people more prone to arrhythmias, right? The longer the action potential, the bigger the chance they can have an arrhythmia. So that's how it causes the direct cardiac damage, or how the heart damage can cause arrhythmias. What about the vasculature? So we know that the vascular system is also affected by COVID. When COVID affects the vascular system, it actually causes vasoconstriction, like we talked about the angiotensin 2. This causes hypertension. So imagine the heart is beating against a high resistance or a high systemic vascular resistance. This can cause arrhythmias. It's also causing plaque ruptures. So if you have plaque rupture, especially in the coronary arteries, the patient can have an MI or ischemia or ischemic insult to the heart itself, and this causes arrhythmias. Inflammation, so it can cause prothrombotic changes in the vasculature. It can cause vasculitis, endotheliitis, and also remember the von Willebrand factor is actually living in the endothelial cells, and so that can be released into the circulation and causes further thromboses and blood clots, especially if it's in the coronaries. All right, the lungs. So the lungs are the big organ affected by COVID. And we also hear about the happy hypoxic. So it's an ARDS-like picture where the person or the patient becomes very hypoxic. When our cells become hypoxic, we go into anaerobic glycolysis, because we don't have oxygen to support the metabolic need of the cells. And so we're in anaerobic glycolysis, the pH of the cells become lower. So we have acidic pHs or acidic mediums. This acidosis causes calcium to increase inside the cell and potassium to increase outside the cells. So now it's messing up your action potential, right? Because calcium is still going into the cell. Potassium is outside of the cell and won't leave. So the potassium inside won't leave. So you're having prolonged action potential as well. Furthermore, hypoxia alone can cause gap junction alteration. So there's two ways that hypoxia can affect your arrhythmia or cause arrhythmias. The alveolar macrophages from the lung, right? So these are what our immune system kind of fighting SARS-CoV in the lungs. They can migrate to the heart and cause damage, like we spoke about. It can cause myocarditis. The pulmonary vascular bed, right, with all the thromboses, with all the vasoconstriction, it can increase the pulmonary vascular resistance or pulmonary hypertension, which feeds back to the right atria, which causes atrial tachycardia when the right atrium enlarges, right, because that's where your SA node is. Excuse me. Also, don't forget about O2 supply demand. So when people are hypoxic, the heart does not see the oxygen, right? It doesn't know how it's not getting oxygen if there's a blood clot or just decreased oxygen in blood. All it cares about is it's not getting oxygen. And this is what we call a type 2 MI, or the patient's heart can actually have an ischemic insult because there's no oxygen. All right, so we spoke about the lungs. What about renal? Well, a lot of patients have AKIs. 27% of them, actually. They lose potassium, they lose sodium, their electrolytes are just messed up. The volume also, some people have diuresis, right? So all of this can cause arrhythmias. Drugs and medicine. So a lot of the medication that we started treating patients with who have COVID, especially initially, so the hydroxychloroquine, the azithromycin, a lot of the antivirals that we're still using right now prolong the QTC. How they do that is, well, they block the potassium channels. And so now if you're blocking the medication is blocking the potassium channel, you get a longer refractory period, right? So if anything happens toward that period, you can have early after depolarization or even late after depolarization. Basically, the patient can go into an arrhythmia, right? You're prolonging your action potential. And one of the scariest arrhythmias that we see with prolonged QT is torsade, right? So these are how medications can actually affect arrhythmias and cause arrhythmias in patients with COVID. Immunologic. This is a big thing, right? We all hear about cytokine storm, immune response, and all that for when people have COVID. Well, yes, it has a lot of effects. So your interleukins, which are your immune mediators, right? So interleukin 1, 6, and tumor necrosis factor in particular, have a lot of effects. So they can actually be prothrombotic. They can increase your vascular permeability. They cause inflammatory channelopathies. So they mishandle the calcium, the potassium. This also prolongs your action potential, right? They also inhibit the cytochrome P450. This makes the drugs, the other medications, bioavailability longer. So other meds that they're taking, whether it's antivirals or any other medication that can prolong the QT, now is more available in their blood because it's not being metabolized, because the interleukins are interfering with the metabolism. They can increase your sympathetic tone, either centrally through the hypothalamus-mediated inflammatory response or peripherally through the ganglions, but they basically increase sympathetic tone. This can also cause tachyarrhythmias, right? It can increase your heart rate trying to respond to the inflammation, and also can prolong your action potential in its own. So a lot of the effects from your immunological standpoint prolongs the QT, right? Again, very high risk for arrhythmias for patients with COVID. The GI tract is also affected by COVID. A lot of patients have vomiting and diarrhea. They lose their electrolytes and they lose volume. All this can cause arrhythmias. Neurologic, we kind of touched upon this before. Increased sympathetic response, increased sympathetic hyperactivity causes tachyarrhythmias, right? All right. I like this drawing. I feel like it kind of encompasses or simplifies a lot of the points that I was making. Basically, SARS-CoV causes direct damage to the lung or heart, or indirectly through the cytokines, which affects multiple organs, and or the ion change or the ion channels can increase sympathetic response, can inhibit the metabolism of medication. Essentially, there's a lot of ways that COVID can end up causing cardiac arrhythmias for patients with COVID. All right. So now that we know how COVID can cause or predispose to arrhythmias, what are we going to do about it? So you have a patient just like the one I had with arrhythmias. Is there anything different in patients with COVID than people who have normal arrhythmias or regular arrhythmias without COVID? Well, again, not enough data to support anything. Essentially, you want to treat them similar to non-COVID with a few caveats to keep in mind. Make sure their electrolytes and metabolic issues are correct, because that can also predispose to worsening arrhythmias in COVID. In terms of electrophysiology labs and exposure, a lot of the cardiologies, especially early on, didn't want to rush and bring patients to do ablations or pacemakers or anything like that because of the risk for exposure. And also they didn't know if these arrhythmias would self-resolve versus just continue forever. And then also please pay particular attention to the QT prolonging drugs, especially in patients with COVID. So those who present with bradyarrhythmias and COVID, usually bradyarrhythmias and COVID are transient, and hopefully they will overcome it and won't last long. You can try your atropine or isoprotenolol, and then use a temporary pacemaker. The cardiology literature was recommending postponing permanent pacers for a multitude of reasons, other than exposing the EP lab or the cath lab for personnel. Because it is transient, one, the patient might not need a permanent pacemaker. Two, there's a high risk of secondary infection, because usually when you want to implant something permanent, you want the patient to be clear of infection. And this is a patient with COVID. So is there secondary bacterial infection when a patient has COVID? They don't know. So they were saying use a temporary pacemaker. And then after recovery, if the patient still needs a pacemaker, sure, he might, you can refer him to get a pacemaker. What about patients with atrial tachycardias or tachyarrhythmias? Well, treat the underlying cause. Are their electrolytes okay? Are their volume status okay? Are they acidotic or febrile? Make sure you have all that treated first. Then you can cardiovert, but they're recommending the cardioversion to be only in refractory cases. So if you have a new onset AFib or a flutter and the patient is stable, the recommendation is to start medical treatment. And by medical treatment, I mean rate control, not rhythm. The reason is a lot of the antiarrhythmics will prolong the QT, and the patients with COVID already at high risk for QT prolongation. So the recommendation is rate control. Be sure to make sure that you don't have an interaction with the medication the patient is on from an antiviral standpoint. And if you're starting them on beta blockers or calcium channel blockers, just make sure there's no interaction between them. And then if patients have recurrent AFib or flutter, again, focus on rate control, at least initially in the acute phase of COVID. Ventricular arrhythmias, I'm not going to go into details like Dr. Slovis did, but in general, treat the underlying cause. Is there potassium okay? Is there magnesium okay? Electrolytes, volume status, acidosis. In VTAC storm, amiodarine, lidocaine, and esmolol, again, to be treated like non-COVID patients. Of course, if they're unstable, shock them. In cases of polymorphic VTAC with prolonged QT, make sure their potassium is on the higher side of normal. So you want it above 4.5. Give them magnesium. Stop the meds that prolong the QT, and then you can always overdrive pacing. And then after recovery, if they need ablation or they need an ICD, sure, it can be assessed then. Those with transient cardiomyopathy or myocarditis might need a wearable defibrillator so that they can, it's a vest basically that shocks them out of any abnormal rhythm if they ever have it. What about the patients who have prolonged QT syndrome or have some inherited channelopathy? Well, again, make sure their potassium is optimized. Make sure they're not febrile. Fever is known to unmask Brugada type 1 EKG findings. And then many COVID medications can prolong QT. So again, make sure that they're not on any medications that can throw them into a longer QT. And use a Tisdale risk score. So the Tisdale risk score is not just for COVID patients. It is a score that was there from before, and it's used for hospitalized patients to basically calculate the risk of them having a QTC longer than 500. And so it's on MD-Calc, and it goes off multiple variants like age, gender, are they on loop diuretics, what their potassium is, and how many QTC prolonging drugs. And once you punch in all this information and the numbers, it gives you a risk score. And so if the patient is high risk, for example, the recommendation is to speak to the pharmacist, change one of their risk factors, maybe change one of their medication or repeat EKGs and so on. So it's a helpful guide if you're going to start, if a patient has prolonged QT and you're going to give them, Zofran or some medication that's going to even further prolong their QT. In terms of if patients have a wide QRS, right? So somebody with a bundle branch or pacer, there's actually a wide QRS adjusted QTC formula that gives you an estimate of what their QTC is. And it's basically the QTC interval minus the QRS interval minus 100 milliseconds. So this just gives you an estimate of what the actual QTC is in those patients with a wide QRS. Remember, in the end, all arrhythmias straighten themselves out. And so my take-home points are basically, remember, arrhythmias are very common, more common than you think in COVID patients. They are caused by either direct damage to the heart itself or indirectly by COVID affecting multiple systems and or the immune response, causing arrhythmias. Fix their electrolytes. Make sure their volume status and metabolic status is great. And then make sure they don't have a fever. Treat similarly to non-COVID, essentially paying attention to the interactions between beta blockers or calcium channel blockers and their antivirals. And then last, be aware of the QT. I cannot stress this enough. A lot of patients with COVID, even not on medication, will have prolonged QT. So just make sure you're not making it worse. And thank you.
All right, Leen, thanks so much for that talk. Very timely. And I remember you sending me the highlights of that tachydysrhythmia case where the patient was going through all different types of arrhythmias while you were trying to manage them, and it was in the post-COVID patient. So